welcome Professor Jonathan Sterne to our HDR UK Cambridge seminar. So Professor Jonathan Sterne is Professor of Medical Statistics and Epidemiology in the Department of Population Health and Sciences at the University of Bristol. He's also the Director of NIHR Bristol Biomedical Research Centre and the Co-Director of HDR UK Southwest. And his research interests include systematic reviews and meta-analysis, methodology for epidemiology and health services, causal inference from observational data, and the clinical epidemiology of infectious disease like HIV and AIDS, and more recently COVID-19. He's also the co-lead of the Longitudinal Health and Wellbeing National Core Study and the Convalescent Study using electronic health record to understand the health consequences of the pandemic. And he leads a large team of producing novel and high-impact research on COVID vaccination and long COVID. So Professor Angela Wood and I and other people in our Cambridge team are actually working in collaboration with Jonathan on a series of projects. But this one, it's more like a Bristol work, I think, that you're presenting today.
Thank you, Jennifer. Yeah, so this is what they call a late career researcher slot. And as you just heard, one of the things about being a late career researcher is that you acquire a lot of labels, and you also acquire a team that does the work while you take credit for it. I should start therefore by acknowledging and get this working. Yeah, so here's what I'm going to talk about. I'm going to talk about the OpenSAFELY trusted research environment, which is the environment within which these analyses were done. I'm going to talk about estimating vaccine effectiveness from observational data and methods to do that. And then some analyses, substantive analyses on waning effectiveness of second COVID-19 vaccination dose, effectiveness and comparative effectiveness of third booster doses. And this is the group who are responsible mainly for the work. One of the things that I think has been really extraordinary and a great development in the past few years is the way that because of the pandemic, we assembled collaborative teams, and I guess because of lockdown and because we moved online anyway, geography really stopped being important because we were all stuck at home anyway. And so the Bristol and Cambridge have collaborated. It's just been a fantastic collaboration that's developed over the last couple of years, including with Angela and Sam and Genevieve and Spencer and others in Cambridge, with a team in Bristol. And so similarly, out of some conversations about we ought to really do something about vaccine effectiveness, Elsie Horn and I in Bristol, along with Phoenicia Walker and Tom Palmer, started talking with people at the Bennett Institute in Oxford, in particular Will Hume, and the other colleagues here, and a group at the London School. And then Miguel Hernan also became a regular contributor to the group and a scrutinizer of methodological validity, I think it's fair to say. So yeah, this work in particular was crucial. It has been led by Elsie and Will and underpinned by discussions with Miguel. So OpenSAFELY was developed rapidly during the pandemic as a collaboration between Department of Primary Care at the University of Oxford and Liam Smead's group at the London School of Hygiene and Tropical Medicine, and the two major suppliers of primary care electronic health care records in the UK, that's TPP and EMIS, to provide rapid, secure access to the full primary care record on up to 58 million people. And it really was rapid. Their first paper in Nature was published in Nature in May 2020 and established risk factors for COVID-19 mortality for the first time. And the underpinning principle is that the data never leave the secure environment, that you take the code to the data, not the data to the code. No more sending data sets around the place. Users never enter the secure environment, but when you're an approved user, you can see moderately sensitive results that were extracted from the raw data in a secure intermediate environment. Data sets are defined explicitly using a human readable API, what they call a cohort extractor. So you say, here's the data we want, and you get those data converted, and then your instructions are converted to SQL to run against the real data or generate dummy data. And analyses start by developing your code using dummy data. And everything is fully audited. So the code is sent to GitHub, queries and analyses are tested, everything is version controlled. So here's the workflow. You write it, you define the data you want. That generates dummy data, which you're free to access to analyze locally. So you can develop and test your analysis code. You then, when you're ready, submit the analysis code to the real data. You get your results, which do not include line listings, so you can never look at individual rows of data or individual people's records. And then when those have been output checked for confirmed non-disclosive, they can be released. And the three major components are the GitHub repository, and open code lists. So by design, every code list is shared with everyone else and publicly available. And then jobs.OpenSAFELY, you can see, obviously you should pay attention to me, so you shouldn't do this right now, but you can log on to jobs.opensafely.org anytime and see the jobs that are running against the real data right now. And any code that is ever run against real data is stored and made publicly available. So we can't guarantee that people won't misbehave, but we can guarantee to them that if they misbehave, that will be public and findable in principle.
What is focus?
So obviously, Spencer, Sam can say more about it. But say I want to know about people who've had a heart attack. More than one code is used to define heart attack in electronic health records. So a bunch of codes will be used, and code lists are fundamental to defining phenotypes. And because they're so fundamental, there's also huge waste in the way that people have historically analyzed electronic health record data, because I get an extract of data and I do a load of work defining the phenotype that I'm particularly interested in, and then I publish my paper. And then I move on to something else, and then somebody else wants to do the same phenotype and just starts again. So these code lists are painstakingly assembled, but in the OpenSAFELY model, any code list that is produced is made publicly available. So you can both scrutinize how other people did their work. For example, you could say, this is useless, you've missed half the heart attacks. Or you could say, that's a great code list and use it and not repeat the work. Was I approximately right, Spencer, Sam? There is a seriously bigger learning curve to operate inside OpenSAFELY and these other population scale trusted research environments than having a data set on your laptop and analyzing it using R and Stata. And so you've got it to operate in OpenSAFELY, you've got to use Git and GitHub command line tool, you've got to use the data definition API, you've got to analyze dummy data, you've got to understand the project pipeline, including getting your code checked before it's run against the real data and sending it off. And you've got to understand all the rules to suppress small numbers and avoid disclosure. It is painful. Genevieve could tell you more. It's not like it used to be. But on the other hand, you're analyzing data on potentially the whole population of England, and that's never happened before. So 3 challenges that slow people down are there are no eyes on the real data, and the dummy data does not match the complexity of the real data. So we minimize the risk of re-identification through all these processes. But the truth of the matter is that code runs in dummy data, it then falls over on real data, and then you have to start again to work out all the problems that you didn't resolve in the dummy data to make it work on the real data. We can do extraordinary analyses when we're analyzing data on tens of millions of people, and this is not just true in OpenSAFELY, we hit computation limits. memory limits. It's a shared resource, so things fall over because too many people are trying to run things, or run times take too long. And so there's a lot of work in modularizing code, randomly subsampling and inverse probability weighting, parallelizing. Basically, you can't, it's not a matter of just writing code that works, you're going to write good code. And we have to fit those efficiency improvements into that pipeline. And then OpenSAFELY in particular was designed to produce one line per person data sets. But a lot of the methods that we use require that you go beyond that when things are changing over time in your cohort. So, I mean, these have been extraordinary advances, and we're all working hard to make sure that we never go back, because this is a resource, along with the NHS Digital Trusted Research Environment for England, which contains data on up to 55 million people. That is extraordinary. It wasn't possible before the pandemic. Suddenly it was possible. These things need to be cherished and maintained, but how exactly we're going to maintain them and make them more widely available post-COVID is really a matter of active debate and work at the moment. So let's talk about COVID-19 vaccines. You all know, we all remember the results coming out. Here is the Pfizer trial published in the New England Journal of Medicine, the end of December 2020. And the outcomes were that there were 10 cases of severe COVID-19, 9 in placebo recipients, and 1 in a Pfizer BNT162b2 recipient. And then the AstraZeneca was a little bit more messy, as you'll remember. And they said their headline result was that 21 days after first dose, there were 10 cases hospitalized for COVID, all in the control arm, 2 classified as severe COVID, 1 death. So one outcome is 9 versus 1, and the other outcome is 10 versus 0. And on that basis, COVID-19 vaccines were rolled out worldwide. Now, that was the right thing to do. Broadly speaking, many people are alive and we're all back here without masks on because of the vaccination program. But that is not a full quantitative description of how these vaccines work over time. Clearly, it was impossible to study duration of effectiveness. There were limitations in what we knew about effects on infection as opposed to severe COVID, or on mortality, and so on and so on. And as you know, the result, policy over the subsequent years has been driven by analyses of routinely collected data. Randomized trials provide the best estimates of effectiveness in the real world. I hate the term real world effectiveness unless it's understood to mean such as what you get in randomized trials. But in this example, a host of urgent questions couldn't be addressed in trials. Far-reaching policy decisions have been made using observational data. And like it or not, such studies are aim to make causal inferences about the effects and comparative effectiveness of vaccines and vaccination strategies. Causal inference in the sense of comparing what happens to an individual or group of individuals in one circumstance with what happens to the same individual or individuals in an alternative circumstance. So the development of a theory of causal inference based on counterfactuals has clarified the reasons that we see associations in the real world and helped us to understand and mitigate biases in epidemiology. And that theory says that 2 variables are associated if they're cause and effect. If I do a randomized trial on 100,000 people, I give half of them a statin and half of them not a statin, and I follow them up perfectly for 5 years, I will find an association between assignment to statin and occurrence of myocardial infarctions at the end of the 5 years. Cause-effect relationships induce associations. Common causes induce associations. So in the presence of a common cause of exposure or intervention X and outcome Y, those 2 variables will be associated. And if there is a causal relationship between X and Y, that the association induced by the causal relationship will be distorted by the presence of the common cause. And finally, and this has been appreciated and explained more recently, because epidemiologists have known quite a lot about confounding for quite a long time, the third reason for associations is if 2 variables share a common effect and we condition on that common effect. So that's why, for example, if you look in people who have had a heart attack, prognosis is better among smokers than non-smokers because older age also causes you to have a heart attack, and therefore the association between age and smoking is distorted, made more inverse in the people who've already had a heart attack. So that's called selection bias or collider bias. So 3 reasons for bias. To avoid bias, to control bias, we need to condition or control for the common causes, and we need to avoid conditioning on common effects. So I'm going to talk quite a bit about target trials. We can often clarify the meaning of our analysis and the appropriate analysis strategy by specifying the target trial, by which we mean the hypothetical randomized trial whose results we're trying to emulate. If we were successful in our analysis of observational data, then other than for sampling variation, the results we get would correspond to the results we would get from the hypothetical trial that we wish we had. So if we succeed in emulating the target trial using our observational data, our observational study will yield the same estimates as the RCT. And the fundamental point about this, the reason I find it so useful in discussions with colleagues, is that thinking like this separates the scientific issues, clarifying the question, from the technical one, how should I do the analysis? And Angela's nodding, and I suspect that you, Angela, like me, have conversations with a colleague who knows huge amounts about their area of research, more than I ever will, by an order of magnitude, but comes along and says, I want to do the following analysis. I'm going to get this group, and I'm going to compare them with this group, and I'm going to do this analysis. And my response is typically, what's the question? And when you say, what's the question, you get a reiteration of the analysis that is proposed. And the idea is to start with the question and deduce the analysis. So that idea was, well, actually, this idea is 70 years old. There's a paper from 1953 by Harold F. Dorn, then the chair of the biometrics branch at NIH, who basically said we should think about the trial we wish we had. But Miguel Hernan and James Robbins published this paper in the American Journal of Epidemiology in 2016, and basically said, if you to define your question, define the same things that you would define for a randomized trial. Who is eligible to receive one of these 2 interventions? What are the interventions that will be received? When is the start and the end of the follow-up? What will be the outcomes? And then what is the causal effect that you propose to estimate? Do you propose to estimate the effect of assignment to treatment, the intention to treat effect? In other words, comparing people assigned to one thing or the other thing, regardless of what happened. Or do you plan to estimate the effect of adhering to treatment, the per protocol effect, the effect that you would see if everybody in your trial adhered to the treatment protocol, and then you would plan your analysis. Now, it doesn't say here treatment assignment. In your randomized trial, treatment assignment would be at random. In your observational data, treatment assignment is based on prognostic factors, therefore we expect and need to control for confounding. So, what are issues in estimating effectiveness and comparative effectiveness of COVID-19 vaccines? And the great thing about talking about COVID is that you all know this, because like me, you've lived it for the last 3 years. Firstly, the incidence of COVID, and therefore of COVID outcomes, varied substantially over calendar time. So in this graph, we've got the wild type variant in black, and then the alpha variant wave at the beginning of 21 in blue, and then the Delta variant wave during the second half of 21 in red, and then the takeoff of Omicron late in 21. So incidence was massively varying unless you account precisely for calendar time, you're going to get confounding by calendar time. And the period that I'm going to show you in the analyses I'm about to present is during the rollout of vaccination at the end of 2020, and things peaked after the whatever Johnson lockdown it was. We can all agree it was probably too late. So incidence peaked second week in January 21 and declined from then on. Is there confounding? Well, of course there is. Here are hazard ratios for characteristics predicting vaccination in about 2.7, 2.8 million adults aged over 70, included in OpenSAFELY TPP, which is a data set representing about 24 million people registered with TPP general practices in England. And as is well known, the less deprived the area in which you live, the more likely you are to be vaccinated. That effect appeared stronger for Pfizer BNT162b2 than for AstraZeneca ChAdOx1. People of non-white ethnicity were less likely to be vaccinated. And then people with learning disabilities, people with severe mental illness were less likely to be vaccinated. People who had received flu vaccination in the last 5 years were more likely to be vaccinated, even controlling for other morbidities for age. So we expect confounding. Not quite what happened. I mean, I'll show you the sequence of the rollout was that Pfizer was made available first and therefore was made available to the very oldest people, starting on the 8th of December 2020. And then vaccination with AstraZeneca started on about the 4th of January 21. So because Pfizer was given first, it was also given to the very oldest people. And then more of the people in the sort of 70 to 80 group got AstraZeneca. And then, well, I'll show you some more data on who got what, because who got what was very strongly determined by age and risk. But I'll come to that. So what target trial is appropriate to estimating vaccine effectiveness during the rollout? We, of course, need to account for prognostic factors, confounders, that differ between vaccinated and unvaccinated people. And that includes calendar time. The big issue when you're trying to define a target trial in observational data is to determine the start of follow-up for each person. Now, start of follow-up for somebody who got vaccinated is clear, as it would be in a trial. It's you did randomly assign them to get this vaccine, and then they get it, and everything would be aligned. That would be, you would follow them up from the point of assignment. But in observational data, if your comparison group is no vaccination, there is no particular day on which you receive no vaccination. You carry on receiving no vaccination until one day you get vaccinated. So the start of follow-up for an unvaccinated person is really the choice of the analyst. And one way to conceive your target trial using observational data is to think of a sequence of target trials where on each day and in each region, eligible people who've not yet been vaccinated either are assigned either to immediate vaccination or to remain unvaccinated throughout follow-up. So we imagine doing a separate trial on each day during the rollout. And having done that, we can take each vaccinated person, we can match them to an unvaccinated person, a person who was not vaccinated on that day or previous days. So eligibility for my target trial is, broadly speaking, no recent infection and in the right age group, because everybody was being targeted for vaccination. So I take somebody in the same age group without contraindications to vaccination, and I match them with the vaccinated person, I follow them. And now I can estimate the intention to treat effect just as I would in a trial, combining across all the days on which vaccination took place. But, as you pointed out, the vaccination rollout was both successful and rapid. It was extraordinarily rapid and extraordinarily successful. So here is the cumulative incidence of first and second doses of Pfizer and AstraZeneca. So the AstraZeneca is in blue and the Pfizer's in red, in people aged 80 plus years in the upper panel and people aged 70 to 79 years in the lower panel. And in fact, that kind of answers your question about the differential between the two. You can see the rollout of Pfizer starting first in the oldest individuals. And it was incredibly, it was a triumph for the NHS, wasn't it? Because such an extraordinary proportion of people got vaccinated so quickly. The problem for our target trial is that means that these people who didn't get vaccinated, you know, I go to them on the 5th of January, I find somebody who got vaccinated, I match them with someone who didn't get vaccinated. But that person who didn't get vaccinated will soon be vaccinated. So my intention to treat estimate, simple analysis I'd do in a trial, is not informative because it's going to get diluted by the vaccination of the unvaccinated group. So I need to estimate the per protocol effect, the effect of receiving vaccination or no vaccination in accordance with the protocol of the target trial. And I can do that by censoring people in the no vaccination group when they get vaccinated. But now I'm going to have horribly imbalanced follow-up between the two groups. And if confounding factors that vary after baseline affect the rate at which people in the no vaccine group get vaccinated, I'm going to have informative censoring. So how's this been dealt with? Well, in a sequential specification of target trial, I do the matching that I've already described. And this means, and this is really important, that I can match on time varying factors that vary from when I started my cohort, for example, on the 8th of December 2020, to the date of vaccination. And in particular, I can match people on whether they recently got COVID-19. Because essentially, if you got infected in the last 3 weeks, your probability of being vaccinated is 0. But that's a characteristic that varies during follow-up. Similarly with recent hospitalization, which made you much less likely to be vaccinated. And then follow-up continues until the control individual gets vaccinated. And at that point, you censor follow-up for both individuals so that the length of follow-up and the period during which follow-up takes place is aligned for the two groups. And we can do sensitivity analyses varying that, for example, extending follow-up by a week after vaccination of the control individual. I can include control individuals subsequently in a new pair as long as I've got remaining controls. Now that throws away loads of data because there's loads of follow-up that gets censored and I get matching failures. But the idea is to make sure that we're comparing similar individuals over the same time periods. So the first paper that did that in the context of COVID-19 vaccination was from the Israeli rollout. It published in the New England Journal of Medicine. This is all Pfizer vaccination. And here's what they did. And in particular, they showed very beautifully, and in a way that, as I'll show you, we've never been able to replicate, they got beautiful alignment of the incidence of infection, symptomatic COVID, and hospitalization in the first few days after vaccination, which you would expect because the immune response to vaccination takes a while to develop. So that was the first implementation of the sequential approach in the context of COVID-19 vaccination. So here's what we did. We were estimating effectiveness in people aged 70 plus years. We excluded people with prior SARS-CoV-2 or on an end-of-life care pathway, or with missing information on key demographic variables, estimating the effect of the first dose of either Pfizer or AstraZeneca compared with no vaccination on positive test or COVID hospitalization and all-cause mortality. And follow-up ended, there's a missing statement there on the earlier of 19th of April 21, or when the unvaccinated person got vaccinated. And there's some details of the matching there. Here's the cumulative number of people matched. So most people, we were able to match the majority of people. The main loss of information is through censoring both people in the pair when the unvaccinated person gets vaccinated. And here are the results that we got from this sequential approach. And you can see that by contrast with that Israeli analysis, we've always seen lower incidence of the outcomes in that first week, which tells us that we couldn't control for all of those time varying factors. And the biggest concern, I think, is that, I don't know if you remember the first time you showed up at a vaccine clinic, but there was a sign, I wish I'd taken a photograph of it, that said, if you've got respiratory symptoms, go away. And of course, just having respiratory symptoms would never be recorded in the electronic health record. And if you had, and so if you went away and then subsequently tested positive for COVID, that would be an outcome in the vaccine group because of your previous respiratory symptoms. Not only that, but they did a great job in the NIMS data set of recording vaccination. but they didn't record when people cancel. So you can't really get at cancellations, and in particular, cancellations that happen because someone was sick. And I suspect that that is an insoluble problem for this data set. Now, the alternative approach to doing this, kind of the intuitive place that a lot of people start, and some analyses have been done this way, is to take follow-up, is to establish your cohort, say on the 8th of December 20, follow it over time, and split follow-up into periods before and after vaccination. So you don't throw anybody away, you just split follow-up at the time of vaccination. So vaccination is coded as a time-varying variable that switches from 0, no vaccination, to 1 on the day of vaccination and then stays as 1. And then I can use Cox or Poisson models to estimate a time averaged hazard ratio for ever versus no vaccination. And that should approximately equal the per protocol hazard ratio that I get from my sequential approach. I imagine what the corresponding target trial would be. It would be to establish eligible people at the start of the rollout and then randomly assign them to vaccination at different times during follow-up. There are two significant disadvantages of this approach, which is where we started, I have to confess, compared with the sequential approach. Most importantly, time-varying factors such as infection that occur after the start of follow-up are now time-varying confounders, and standards methods don't work to control time-varying confounding. And secondly, it's hard to estimate. I've been showing you cumulative incidence in each group. You can't really do that when you split follow-up. And this is the direct, I won't spend a load of time on this, but the problem we've got when risk factors vary, are influenced by prior treatment and predict future treatment when treatment varies over time, is that this variable C is on the causal pathway from treatment X to outcome Y, and it's a confounder. So it's a confounder of X at time 1, but it's on the causal pathway from X at time 0 to the outcome. So conditioning on it causes bias because, well, if there's a measured common cause of C and Y, I induce an association between U and X0, and not conditioning on it means that I've got a measured confounding. And that problem was identified by Jamie Robbins in this completely impenetrable paper, which is more than 100 pages long and published in 1986. A new approach to causal inference in mortality studies with sustained exposure period, application to control of the healthy worker survivor effect. I mean, Jamie Robbins is a genius, but it took a very, very long time because before anybody, well, other than a very few people understood what he was talking about. He was talking about that problem, basically. And then in 1999, he, along with Miguel Hernan and Babette Brumbach, introduced marginal structural models to deal with the same problem of time-varying confounding. And the trick with marginal structural models is to avoid conditioning on those time-varying confounders and to use inverse probability weighting instead, so that at each time, whether you start treatment, in this case vaccination, is unrelated to your time-varying confounders. In general, Robbins has been responsible for developing these G or generalized methods to estimate causal effects in the presence of time-varying confounding. The one that was introduced in 1986 is the G formula. And if you go along to their group in Harvard, you will inevitably hear them say, it's the only formula you need for epidemiology. Everything that is done in epidemiology is a special case of the G formula, or you can use G estimation, which I won't talk about, or you can use inverse probability weighting of marginal structural models. So is there time-varying confounding? Absolutely there is. So we looked at time since discharge from an infectious or a non-infectious hospital admission, categorized as in hospital or 1 to 21 days or 22 to 28 days ago. And you can see that people who had been hospitalized were less likely to be vaccinated. And that is something that happens during the rollout, and therefore you can't just condition on it at baseline. And even more importantly, almost no one was vaccinated within a week of a positive test, because you weren't supposed to get vaccinated in a week of a positive test, and few people were vaccinated within a month of a positive test. And that meant that even inverse probability weighting wouldn't work, because you essentially got non-positivity. There was almost nobody who you could upweight to represent all the people who didn't get vaccinated. So single trial approach was based on 2.8 million people. Follow-up started on the date of eligibility. We had a row of follow-up for each person, which is how those hazard ratios were estimated. And to deal with this prior infection problem, the solution is to change the causal question. So people are ineligible for vaccination if they've tested positive. So we simply didn't update the time-varying vaccination status after you tested positive. So the causal question becomes comparing people who were either vaccinated or who tested positive with unvaccinated people. Here are the results when we finally estimated the effects of first COVID-19 vaccine. And I've already highlighted that by contrast with the Israeli paper, we never could get rid of the apparent protection soon after vaccination. That is simply implausible. And also we get quite substantial differences between the sequential trial approach, broadly speaking, producing estimates of greater vaccine effectiveness, hazard ratios further from 1, than the single trial approach, the splitting follow-up approach. Although remember, we have changed the causal question for the splitting follow-up approach. Now, I'm not going to spend any time on that. We started doing that 2 years ago, and we had such a nightmare doing the marginal structural models that it got delayed and delayed and delayed, and everybody else published their papers, including papers with some of the methodological flaws that I've talked about, and we had failed to finish our analysis. But what we've done is that next week, this is all going to be published in this research methods paper in Annals, which actually tries to explain these two approaches to specifying a target trial. So I'm hoping that some good will have come out of what, in terms of an applied exercise, was a complete waste of time. Let's move on to stuff that I hope was less of a waste of time. So I'm going to talk about 3 sets of analyses that we've done since then. This one is the least target trial related analysis. It's looking at waning effectiveness in Pfizer and AstraZeneca vaccines over 6 months since second dose, published in the BMJ last year, work led brilliantly by Elsie Horn. And as you all know, vaccination was rolled out strictly according to risk groups, and we were always worried when we were seeing these analyses about the difficulty in aligning periods of follow-up according to when you got your second vaccine, because that was very different for different risk groups. So we started analyses at 2 weeks after the date of the second vaccine dose, as you can see here, and then split all the follow-up into 4-week intervals after that. And we used Cox models to estimate the hazard ratio of 2 doses versus no dose. And then we meta-analyzed across those independent intervals to estimate to quantify waning effectiveness over time. So we stratified everything by vaccine eligibility group, because that was how the rollout was defined over time. We matched everything exactly on calendar date. And this kind of speaks to the question that you asked earlier on. This is the rollout of second vaccination in the 60 to 5-year groups. And sorry, well, you can see here. So the orange is 65 plus, green is 16 to 64 years and clinically vulnerable, defined using electronic health records. Blue is 40 to 64, and purple is 18 to 39. And you can see the peaks of vaccination. It all overlapped, but obviously very different for those 4 groups. So everything is stratified in fact, within eligibility groups, within those broader groups. Clearly, the unvaccinated group becomes highly selected, and we controlled for the widest possible range of confounding factors we could think of using these detailed linked OpenSAFELY data. We removed, when people got further vaccinations, we didn't censor them during the time interval in which they received the vaccination, but we censored them subsequently at the beginning of the next interval. And then, of course, vaccination continued throughout follow-up, both because of the occurrence of third doses in people who'd received 2 doses, and because of the occurrence of first doses in people who had previously been unvaccinated. And again, we censored on that, but only at the start of the next interval. And we removed people with evidence of previous infection. And we analyzed these 4 groups, and here are our results. So AstraZeneca is in gold and Pfizer is in blue, or whatever the BMJ want to call that, those colors. It's not a surprise, you'll all know that although AstraZeneca was effective, Pfizer was more effective. So these hazard ratios, just to remind you, this is the rate at which your events occurring if you were vaccinated compared with the rate, divided by the rate in the unvaccinated. So the hazard ratios start at somewhere around 0.1, which corresponds to 90% protection, and end in this group at about 0.2, corresponding to 80% protection. So and then in the upper set of panels, we've got vaccine effectiveness against COVID hospitalization, and in the lower panel, vaccine effectiveness against infection. So if we talk about, I think a couple of striking things about this. Firstly, lots of people were saying that effectiveness waned in, at different rates in the different groups. And quantifying it like this, we were really surprised by how consistently effectiveness waned across these very different risk groups. The slopes of the lines look pretty similar to each other. If you look at infection, there was essentially either no protection against infection, or infection was actually higher in the vaccinated group by the time you got to 23 to 26 weeks after second dose. That was really marked in the younger individuals, probably because a desired effect of vaccination is to allow people to socially mix. And if you socially mix more because you're protected against severe disease, you become more likely to get infected when vaccine doesn't confer much, if any, sustained protection against infection. And then the other thing to note is that who got what? Well, hardly anybody in the 40 to 64 year group got Pfizer because they run out by then. So we all got AstraZeneca. And then, of course, by policy, they only, because of the concern about thrombocytic thrombocytopenia, policy decision was made that only Pfizer and then Moderna would be given to the 18 to 39-year-olds. We didn't have enough data to look at Moderna in this analysis. So the summary of that was that the rate of waning was strikingly similar across outcomes and risk-based subgroups. And although there was essentially no observable protection against infection, protection against hospitalization and death, COVID hospitalization and COVID death, remained high 6 months after second dose of both vaccines. I'll quickly show you work we've been doing on boosting. Firstly, booster compared with no booster. That's in people who've received a second vaccination, using the sequential approach. So we're matching individuals who received an mRNA booster with individuals who were eligible to be boosted, so they already had 2 doses, but didn't get boosted. And we're using this approach of censoring both people when the control gets boosted. We got really good matching coverage, but more boosting that was done with Pfizer in the red than Moderna in the blue. That's Moderna mRNA 1273. Now, we started off looking at COVID outcomes, and then we'd been receiving reviewer comments on earlier BMJ papers that we should really look at negative controls, and eventually we decided that they were probably right. So we decided to add to our previous list of outcomes cardiovascular death and cancer death and fractures. And we've now got 7 outcomes to look at, and that's a bit small. So I've split it into the upper 4 here, which are the COVID outcomes. So this is boosting compared with no boosting over 6 months from the time you got boosted using the sequential approach. And you can see that the cumulative incidence of infection by 6 months, there was small protection against infection early on, but the cumulative incidence of infection was higher in people that didn't get boosted by 6 months. There was sustained protection against hospitalization and death, which justified the boosting program, and much lower risk of non-COVID death. Now, at that point, we should probably have stopped, but we had decided to be good epidemiologists and look at negative control outcomes. And the first one we looked at was fracture. Now, it's really hard to argue that anything is a proper negative control outcome for COVID-19. Because it's plausible that getting COVID-19 makes you weaker and more likely to fall over and fracture something. So I can't argue, we haven't got perfect negative control outcome. But for fracture, we saw modestly lower rates of fracture in people who did and didn't get boosted. Might be a real effect, might be confounding. But here's what we really regret doing, is looking at cancer death and cardiovascular death. Now, there's been loads of discussion about the thrombotic consequences of COVID, and it's just about plausible that COVID provides substantial protection against cardiovascular death. But I'm struggling to believe that vaccination boosting protects you 80% against cancer death. I really am. I'm looking to John for something plausible here, but I think that says that we can't control the confounding. The interesting thing is, I think there's been quite a few papers that have published results that are broadly consistent with these outcomes here, that have said, look, the boosted program was a great success. Almost nobody has looked at non-COVID outcomes. So at the last meeting of the UK HSA, Health Security Agency regular meeting to discuss vaccine effectiveness, I shared these results and I said, other people should really do this, I think. Quickly show you our Pfizer versus, this is direct comparison, final one, of Pfizer with Moderna boosting. And what we got here was modest benefit, certainly modest short-term greater benefit of Moderna compared with Pfizer, that then attenuated over time. So again, this is infection, positive test here. This is hospitalization, and then we've got too few deaths to really say anything at all. But with the numbers you can analyze in these very large trusted research environments. So these are hazard ratios overall for positive test and for COVID hospitalization overall. And then according to the primary cause vaccination and age and previous infection and clinical vulnerability. And there's just a suggestion, but it's not definitive, that the advantage of Moderna was greatest in people who had previously been vaccinated with Pfizer, which could be something to do with heterologous immunity, but it's not definitive. I will conclude. Whether it was a good idea or not, well, it was inevitable that decision-making about COVID-19 vaccination, one of the most important public health interventions of our lifetimes, was driven by analyses of observational studies based on routinely collected data. We would continue to argue that studies of comparative effectiveness as treatment strategies are facilitated by specifying the target trial whose results we wish to emulate. I think that's generally an extremely useful underpinning approach to doing pharmacoepidemiology and examining where there's a deficit in randomized trial results from randomized trials. point about the approach is specify the question and then deduce the analysis. Don't start off by saying the analysis that you're going to do. We can't study vaccine effectiveness against infection anymore because of the ending of testing. But I think there are still really important questions about the timing of and eligibility for booster vaccination. And we're still looking at fourth doses. And now the emergency is over. Some of these final results that I've showed you suggest that we need to consider carefully the advantages and limitations of different approaches to estimating vaccine effectiveness. And I just note that many studies have only reported COVID-related outcomes. And if we can get the resources to do it, we should compare different approaches and start looking at a wider range of outcomes to unpick the extent to which there were residual biases that couldn't be controlled. Thank you very much.
Oh, that was a lot of very interesting results. So I have some questions, but I'm going to give a question to you, if you have any. Yeah, Sam.
Yeah, it's just about we try to avoid any but that's really so should we be actually writing instead of saying that we are actually aiming on the study as ethnic associations, keep saying things like we're trying to emulate target trials and then see whether indications is not.
So Miguel, as usual, has summed it up beautifully. And if you don't know it, you should go and read his paper, which is called The C Word, which is causal, don't worry. But basically, epidemiologists for years and years and years have written in the introduction that they're trying to estimate an association and written in their results that they have found an association, and then discussed in their discussion that association is not causation, and then reached causal conclusions. I mean, I've got a beautiful example if you're interested in it from a BMJ biobank paper, in which not only so firstly they start to hint at causation in the conclusions of the paper, and then there's an editorial which gets stronger still about causation, and there's a news conference which makes causal claims, and then finally the front page of the BMJ makes a straightforwardly causal claim based on this paper that said it was looking at associations. So absolutely, as a completely general point about epidemiology, we are often trying to make causal inferences. And instead of the old cliche that association is not causation, which of course it isn't for reasons that we well understand, if we are trying to make causal inferences, we should specify that we are. We should explain what was the causal inference we were trying to make, and then we should carefully address the potential biases that might undermine our causal inferences. And that is so much better than mealy-mouthed words about associations not being causation. Yes.
So brilliant stuff. Question for you is about the extent to which you think the approaches that we use here squeeze out the potential confounding effects of different variants. Because it's really important. We need to help us think through variants. Severe disease outcomes. It's the case. And for geographical regions at different times. Also driven by other factors like do you think the methods that we use here for calendar time matching would squeeze those, what extent would they squeeze out those types of boundaries, maybe on the geographical and other types of patterning? I think you may have taken that to account, or maybe you could talk us through how you thought about that type of
So one of the distinctions between the Israeli analysis I showed you right at the beginning and our analyses is that they controlled extremely tightly. They matched extremely tightly on geographical location. And that, as I remember, was particularly important in Israel because there were these very concentrated areas in which ultra-Orthodox people who didn't like vaccination lived. And obviously the shape of the epidemic was very different in those areas. So we matched within regions, but we didn't match within very small areas. And maybe that's one of the reasons that there are strong suggestions of unmeasured confounding in our analysis. But in principle, the great thing about these data sets, limited only by constraints on the data available, is that you can, in principle, match very precisely on region and therefore control for small regional variations, which certainly occurred, as we all know, in the incidence of COVID during the pandemic or in the incidence of some other infectious disease at some other time. So we have done some analyses, particularly, I think, really the booster era was, of course, started with Delta and became Omicron. So you can split follow-up time into an Omicron period and a Delta period. But of course, you can't look at vaccine effectiveness against wild type because no one essentially was vaccinated, other than in a vaccine trial, no one was vaccinated against wild type. So you can split follow-up time into different variant eras, but there is very little ability to examine the same group of people vaccinated the same time ago in different variant eras because everything happens so quickly in terms of the rollout of vaccination in those individual groups. The analyses that the Cambridge Bristol group are doing involve a pre-vaccination 2020 cohort looking at the effect of COVID and a vaccinated and unvaccinated cohort in 21. And my broad impression of all of the analyses we've done so far is that the primary driver of is that vaccination reduces COVID severity, and it's the severity of COVID that influences the outcome. And probably the changes in variant were, I guess, my impression is that the changes in variant were more important in terms of immune escape to vaccination, allowing continuing replication in the presence of vaccination than they were in terms of severity of COVID if you were unvaccinated. But it may be that there was a claim right at the beginning of the Omicron era that Omicron was less severe, but I think that was very heavily confounded by Omicron occurring mainly in vaccinated people. So I'm not sure that we know, but I suspect it's all about the vaccination and the prior infection. Not all, mainly.
Thanks for the great talk. I'm kind of in equal parts awestruck and horrified by it. Awestruck that because I know how complicated these analyses are, but I'm horrified that dozens of people have spent 3 years on something and still got results which aren't going to be confounded.
Horribly.
So obviously you talked a lot about negative controls, and I can really see the value of that. Are there any other approaches which you think would be able to distinguish between residual confounding versus to detect how much residual confounding is involved?
Most studies that drove decision making in certainly the UK were done using, I haven't talked about it because there wasn't time, but were done using this test negative design, where you took people who tested and you, broadly speaking, it works in an era of mass testing, of course, but you, broadly speaking, compare people who test positive with people who test negative. And the idea is that people who test are much more similar to each other than just everybody. When I say here that we should think carefully, that now is the time to really go back and compare these different approaches, I'm kind of referring to the test negative design as part of that. I suspect that, so the the issue of time varying confounding, I suspect, is most severe soon after vaccination because of postponement of vaccination in people who are about to experience an outcome. I can't prove that, but it's plausible that that is. And it's also plausible that if we'd matched a lot more finely, we might have done better. So you could go back, I mean, it's certainly feasible to go and match more finely and see if that makes a difference. It's also plausible that after a few weeks, you're getting quite robust estimates of effectiveness, and it's only that very early period that's horribly biased. But we really worked hard to get rid of that bias. So if there was an easy way to do it, honestly, we would have done it.
I was thinking of your negative control for like the cancer non-COVID outcome. I'm thinking actually if someone has stage 4 cancer, maybe they will never get vaccinated.
But we've worked quite hard to reduce, we've worked quite hard to remove those people. It's a question of whether your ability to remove those people who are never going to get vaccinated, based on the information available in the electronic health.
So we reached time. Maybe one last question from Sam, and then we stop there.
I guess with that, do you think the match saw the same event of vaccination, like number of number of vaccines, it seems like the form of like left five cancer one is that healthy people are healthier if they get vaccinated. Sick people don't get vaccinated and then they get cancer.
So
like sick less.
So we worked hard when we first saw the kind of extreme implausible early hazard ratio. We said, okay, one obvious thing to do is to identify people on end of care pathways. So Will Hugh and his colleague went and did a load of extra work to identify and exclude people on end of life care pathways. Problem is, you can't perfectly do that, or else that's not the whole problem. So I would say that in the analyses I've shown you, they're broadly matched, not finely matched. But of course, we're still able to, if we've got measured confounders, they can still be controlled for in the standard way. I mean, the really important point about sequential design is that you're starting follow-up on a specified date, and you're measuring your confounders up to that date. At that point, at least in terms of methodological theory, matching, you should be, it doesn't really, it's not so important whether you match on something or control for it in the analysis. What matters is that you measured your confounders up to the point at which interventions occurred. So we could certainly go back and work harder at the matching, but I think we reached the limit of what we could do in the electronic health record, at least within feasible time. But I think there's a real research agenda here because, as I say, I'm enthusiastic for the use of explicit specification of causal questions as a means to design analyses to answer questions in the absence of trial evidence, but with our eyes open about the need to carefully mitigate bias as far as we can.
So I think we will finish this time, but I can tell you we have a few questions in the chat, so if everyone is okay, we might. I think we've answered one of them already.
Yeah, second one. So there's one from Will who asked whether you think oops, another question came in. So, whether you think prioritizing a target trial framework causal inference may potentially limit the types of causal questions we set out to ask.
Limit the causal questions. I mean, I think by implication, I'm specifically talking about healthcare intervention. Well, I'm specifically talking about healthcare interventions. So, for example, thinking about the causal effect of LDL cholesterol or HDL cholesterol on subsequent cardiovascular disease, there's a whole further level of difficulty about what it means to do. How would you define that causal question? So, I've at least implicitly limited myself already to interventions that have taken place in healthcare and are recorded in electronic health records. Beyond that, when you start to think about these questions and you start to think, how might we realistically be able to control the confounding, you often can reach the conclusion we simply can't. Because the start point has to be that you can identify a set of patients or people who are eligible to receive one or another treatment or treatment strategy, and that you have reason to believe that the variables that determine whether they got one or the other treatment strategy are available in the electronic health, available in your data set, in your EHR data. And in some circumstances, that may well be true. For protocol-driven treatments, that may well be true. In other circumstances, you may conclude, we know it's being driven by this, the doctors can see this, it's never written down, we can't control the confounding. But the underpinning framework is still really useful because it forces you to define your question and to think about the drivers of getting one or the other strategy and to define your eligible population. And many analyses skip that step and go badly wrong when they don't need to. So it's not a guarantee that you'll get the right answer. It's a way of identifying potential problems and setting out to mitigate them. And it does constrain the questions that you can realistically do.